Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about cirrhosis of the liver. When I left off last week, I was talking about how one goes about evaluating someone who one might suspect have cirrhosis or known to have cirrhosis of the liver. Cirrhosis of the liver is a very common problem throughout the world. There are 500 million folks across the world who have cirrhosis of the liver for one reason or another. In this country, there are 5.5 million folks who have cirrhosis of the liver, and 25,000 folks died of cancer, of cirrhosis of the liver every year. Okay, so it is a very common problem, and I've given you the list of things that can cause it to occur, being alcohol being number one, obesity in this country being number two, hepatitis B, C, D, E being number three, and the rest is, the list is extensive. Now, when I left, I was speaking about, I get to the point where I was talking about doing the blood count after we finished the examination, etc. Now I'm going to proceed to talk about some of the really most important tests that we have to do to evaluate the liver, namely the so-called liver function test. What are the liver function tests? Well, the liver function tests include the SGOT, the SGPT, the alkaline phosphatase, the total protein, the serum albumin, the total bilirubin, the indirect bilirubin, etc. The calcium also is included in part of that. Those are very, very important things. But another test that is just as important, besides the proton time I mentioned last week, that gives us an idea how much good liver we have left when someone's liver is sick. The proton time should be normal. If it's normal, we know we have still some good liver left. If it is abnormal, then being that it is elevated, then we know the liver is in serious problem. Is of course the serum ammonium level. Ammonium is a very important part of this whole process. The ammonium pathway began in the large bowel, and it finds its way into the liver. The ammonia is processed in the business of making protein and amino acid, etc. When the liver is sick, once the ammonia is produced in the colon by the action of the bacteria that reside in the colon, the liver cannot handle the ammonia, and therefore the patient ammonia becomes very toxic to the body, and the person can go into coma, the so-called hepatic coma. Now, that is, it can happen via many different ways. When I get to talk about complications of cirrhosis of the liver, I will explain some of the other ways that can cause the level of ammonia to become elevated, namely bleeding, which is one of the most common problems associated with cirrhosis of the liver. So you would do the what's called SMA-20, that's one term for it. Another term is SMA-12, meaning just the liver function test without the renal profile, that's SMA-12. If you include the renal profile in it, it becomes SMA-20. Nowadays we call it complete metabolic profile. That's another. These are the three terms that are out there. Again, this chapter, I believe chapter 59 in this book, has a big section, a big chapter on cirrhosis of the liver, and it details all this stuff that I'm telling you in much more detail than I have time to discuss with you on television. So if you have a chance to take a look at it, this book is called it's such a big book, The Best of Clinical Medicine for the 21st Century. I wrote this book. It has 110 chapters, 812 pages, I think, and it came out a few months ago. You can, I'm sure, get your hands on it, or you can also find it on local public libraries or whatever. If it is clinical medicine that you're really interested in, a truly hard-nosed, well-detailed, well-understood clinical medicine, no matter the subject, for throughout the world. By the way, this book covers medicine throughout the world. take a look at it, and you will learn a whole lot of stuff in there from this book. Now, so you will do this test. You will see how abnormal the SGPT is, how abnormal the SGOT is, and how abnormal the alkaline phosphatase is, etc. LDH is also part of the liver function test, but we don't do it routinely anymore, but we get it for specific reasons. When we want it, we add it on, etc. So you do these tests, and the bilirubin is very important, because when the liver is very sick, this is the liver right here. The liver produces the bile, and some of the bile gets stored into the gallbladder, which then pumped it into the stomach to help digest the food that we eat. The color of the stool, which is brown, is because of the bile. When one has blockage of the bile, the stool is clay-looking, will look like whitish, clay-looking, etc. So we absolutely cannot survive in a healthy way without having a very healthy liver. So now that we get these tests, we see how elevated they are, then we will proceed to, as I mentioned last week, to get a liver biopsy. And before you do the liver biopsy, again, you need to know what the prothrombin time is, what the partial thromboplastin time is, and you also need to know what the platelet count is, because if the platelet count is very low, it is very risky to put a needle in the liver, because the person is likely to bleed. The same thing applies if the prothrombin time is high, and the partial thromboplastin time is also very high. It is very risky to do liver biopsy, especially if the liver biopsy is being done by gastroenterologists who are expert in this field, who train and experience about and doing liver biopsies. However, we could bypass that these days by going to the interventional radiologists that have techniques whereby they can actually visualize the liver. When the gastroenterologist is doing the biopsy, he or she is doing it blindly. When the interventional radiologist is doing the liver biopsy, he or she is actually seeing the liver through a CAT scan of the abdomen, and then he or she will thread, clean the area naturally, local anesthesia, and will thread the little tube there. And these specialists are just amazing. They are fantastic what they're able to do. And they'll go in there and then take a tiny little piece of the liver and take it out, and then put it in its proper solution, send it to the pathologist to be evaluated. Once the pathologist gets that, she will process it and evaluate it. They evaluate the different degrees of scarring, inflammation, etc., and other abnormalities that they can see in the liver, and they are expert at that. They will tell us how bad really the liver situation really is in terms of the chronicity and extensive nature of the cirrhosis. So that's very, very important. In addition to that, these days, as I outlined in this book, in this chapter 59, I think, there are newer, fancier tests that we have available, which I wouldn't bore you by detailing them, that further evaluate the tissue, the liver, to tell us really what really is going on. But going back from the beginning of time, then medicine become a formal field of practice. Cirrhosis is cirrhosis. These newer techniques are helpful, but the bottom line is, once the liver is cirrhotic, it is cirrhotic. And then the question is how you go about dealing with it, okay, so that the person can survive and then live a normal life. Well, it's not easy. So, you will go ahead and do an abdominal ultrasound, as I mentioned. The abdominal ultrasound will visualize the liver, the gallbladder, the pancreas, and all the organs in the right side of the abdomen, which is where the liver is located. The spleen is located in the left upper part of the abdomen. That's where the spleen is located. And of course, the liver is located on the right side of the abdomen. And then you will then proceed to decide what to do for the patient, okay, in terms of treatment, et cetera, et cetera. Now, again, when I left off last week, I was talking about this very interesting and complicated issue of secondary hyperaldosteronism, which leads to accumulation of fluid in the abdomen called ascites and swelling of the rest of the tissues around the body by third spacing with, because the liver cannot produce sufficient albumin, and albumin is necessary to maintain the so-called oncotic pressure, which prevents fluid from moving from one compartment to another, as it were. So the liver cannot do it. Now, if we come to a point where we really have to do somebody's biopsy, we absolutely must do it. Well, there are things we could do. If it is that necessary and it is crucial, then we could also give the patient some fresh frozen plasma, nothing wrong with that, which will transiently correct the prothrombing time and the PTT, and or bypassing that, we can give them some vitamin K. Vitamin K will go a long way as well. Within 24 hours, that can lower the prothrombing time to some degree and allowing the procedure to be done. Again, we could also transfuse somebody with platelet. We can do this thing if we have to. If we have to, because there are certain degrees level. If the platelet count is above 60 to 70,000, it's reasonably safe for surgery to be done. It's also reasonably safe for needle biopsy to be done by the radiologist who specializes in this kind of stuff. It would be chancy, however, for the gastroenterologist to stick a needle which is much larger blindly in somebody's belly whose platelet is 60,000. You are asking for trouble, and bleeding can occur. It is also important to mention people take all sorts of stuff over the counter. People take NSAID day in, day out for different aches and pains, fever and whatever. People take cough medicine. Most of this stuff have aspirin to one degree or another in it. You cannot, let me repeat, you cannot have liver biopsy if you take an NSAID 24 hours before. You can't. If you do, you're going to bleed extensively, okay? Because the NSAID will interfere with the quality of the platelet, preventing the platelet from aggregating, and you run the risk of bleeding. And people have bled and gone into shock and lost their life that way by taking NSAID. The same thing happened. If you're taking certain medicine, tell the doctor that you are taking these things, because some of these things have aspirin in them. Aspirin is a fantastic medication, but one of the reasons some of these things work, because unknown to you, they have aspirin on them, so you have to ask. If you take this stuff, tell the doctor, so that, because I'm talking about the quantity of the platelet, but these are dealing completely with the quality of the platelet. Very, very difficult issues, okay, that will cause you to bleed because the platelet cannot aggregate. Once one creates a wound of one type or another, whether you cut your finger or whatever, the platelet is the first line of defense that becomes aggregated to try to seal the area that's been cut. Well, if you take NSAID, the NSAID, by the way, you don't have to give it, people don't understand how it is. The NSAID affects the platelet up to 6 hours. Let me repeat that. The NSAID affects the quality of the platelet for up to 6 hours. No more than that, 6 hours. Aspirin, however, affects the platelet for 7 to 10 days. 7 to 10 days. There's so many misunderstandings out there where people will tell people, when you're going to have surgery, don't take NSAID for a week before. That's completely bogus. Makes no sense. 6 hours, okay? So that's the extent of the effect of all NSAID to the human platelet, period. Okay, so if you take NSAID 24 hours before, that's not going to cause you to bleed if you're having surgery. If you bleed for surgery, you bleed because of something else, but it's not because of the fact that you take the NSAID. However, if you take aspirin, that's a different story. Aspirin lasts for 7 to 10 days. If you know that you did these things, you still have to have the test done. Then call the hematologist. The hematologist, he or she, will give you a medication called desmopressin. The desmopressin will be given to you intravenously. Once you get the desmopressin, which is basically doesn't cause any side effect other than by the flushing, it will increase the factor VIII van Willebrand by between 15 and 20% and normalizes the quality of the platelet within an hour to an hour and a half. Okay? So you don't have to cancel surgery if you know what to do. You just tell the person, the doctor, the surgeon what had happened, or he or she really have to have that surgery done. Or for that matter, it's an emergency, okay? It's an emergency and you know your patient was on aspirin, or the patient or the family knew the patient is too sick to tell you, look out on the wallet to see what medication they were taking or whatever. Then why cause this patient to bleed massively on the operating table where they can develop shock and die? If you just simply realize that they were doing this stuff, just give them. I have experienced once a patient of mine at a hospital that I should not name who had surgery for colon cancer, young man. He now lives in Florida. I believe in so many years later, he still called me every Christmas, he and his wife, to say Merry Christmas or Happy New Year, whatever. Well, there's an NSAID, I think it's Toradol. That's what the name of it, Toradol. It's an injectable thing. For whatever reason, it's beyond comprehension. Surgeons, and I'm not criticizing them, surgeons, because they're great doctors, have a habit of giving people post-op Toradol for pain. Toradol is an NSAID. For crying out loud, you just did surgery on someone. You did a fantastic surgery, great surgery. Why give them Toradol? They're going to bleed. There's so many other pain medication you could use to give somebody who needs pain medication. Why Toradol? Toradol is an NSAID, okay? So, and this poor guy bled, requiring 4 units of blood, went into shock. And I, to this day, I'm paying the consequences of having to be rushing. I think I was living in Walkland in those days, rushing across the Tappan Zee Bridge like a madman to make it to this hospital in Westchester so that I can intervene, because the guy was about to be taken back to the OR. He was going to die to the OR. And all I found out that I read the chart, this man had gotten Toradol, and he was bleeding profusely, post-op, about to go into shock. And all I had to do was to say, hold on, time out, please, time out. I give the guy some desmopressin. An hour later, the bleeding stopped, and this guy's life was saved. And it turns out to have had stage 1 colon cancer. The surgeon had done a great surgery removing the cancer. The man is alive today, but he was going to die because he got Toradol. And then, of course, to this day, the surgeon is mad at me. Every time he sees me, he look the other way. If he could kill me, he would kill me, because I didn't make him look bad. I'm just trying to save my patient, which I did. I'm still paying the consequences because I intervened on my own patient in the middle of the night, 3 o'clock in the morning. And then an intensive care unit that I will not mention in the hospital. I saved my patient's life by doing something simple. They should stop using Toradol intramuscularly for patients who had surgery. Give it when the bleeding has stopped, give it at other time, but why when you just did surgery on somebody? It's just complete failure of understanding physiology and medicine for something so silly to happen. Well, again, as I said, many years later, some 25 years later, this guy is still mad at me. Okay. So whatever. In any event, a lot of them are mad at me anyway. So be that as it may, you do all this stuff. Now you're getting ready to send the patient to have the procedure for the liver. You also have to be very careful. You have to be very careful. You have a patient with a very sick liver, okay? This patient also likely to have another complication, which I haven't even gotten into, something called DIC. Because the inflammatory process that's going on, the inability of the liver to be able to get rid of the glycoprotein can cause the patient to develop disseminated intravascular coagulopathy, something called DIC. So how do you figure that out? Well, you go to the laboratory. You look at this. You look at the red blood cell under the microscope. They'll be fragmented. You will see fragmented red cell under the microscope that tells you the patient has DIC. Okay, patient has DIC, and he or she is going to bleed like mad. Okay, so in any event, that's crucial. So so now that you got your patient, again, as I mentioned to you, when I get to talk about complications of cirrhosis of the liver, you will really understand how bad things can really get. Okay, so you get your biopsy. Now you have to decide what to do. The patient is cirrhotic. Well, one thing, if it is alcohol, the patient has to cease drinking alcohol. If it is hepatitis that's causing the problem, you need a viral load. The viral load will tell you, number one, how many millions copies of this virus that you have in the patient bloodstream. So you have to understand the virus live in the liver as well, and that will give you an idea. And then not only that, now you could do the genotype of the different vaccine. There are excellent medications out there now that are being used to treat the hepatitis. If you treat the hepatitis, the insurance company will pay for this, hundreds of thousands of dollars this medication can cost you. Then, of course, that will alleviate the problem in the liver, and the liver might still function better once you remove the viruses from the system that's causing recurrent inflammation, etc., etc. So you will do that. When I get to talk about treatment, I will get into all this kind of stuff, okay? So now you've done your abdominal ultrasound, you've done your biopsy, now you know you have cirrhosis. Now let's begin to talk a little bit about some of the complications. It's fascinating. One of the things that happens, first of all, is, as I mentioned before, because the liver is cirrhotic, right here, the liver is cirrhotic, there's going to be occlusion throughout the liver of the small, the tiniest, medium-sized vessel, etc. There's going to be occlusion. Because there's occlusion, there's a back pressure, and that pressure goes into what's called the portal system, causing portal hypertension. On the left side of the abdomen would be where the spleen would be located, right here on the left side, okay? So that then causes the spleen to become enlarged. The spleen can become enlarged for a variety of things, but portal hypertension is one reason that can happen. So once you have an enlarged spleen, then a whole host of things will likely develop. Among them, of course, is pancytopenia. Namely, you have low white count, low red count, low platelet. Because the spleen is enlarged, it's sucking up all this stuff from the circulation. So all these 3 cell lines that we need to live on are going to become abnormal. Okay? Going to become abnormal. And as I mentioned last week, there's another problem, namely that the liver is so sick, the liver cannot clear out the breakdown product of protein called glycoprotein, so they stay in the circulation. They coat these cells. As they coat these cells, the spleen and all the other mononuclear cells are reading them as foreign substance and sucking them out like scavengers. So that's another mechanism through which you're losing these cells, okay? Okay, now, and then of course, once that happens, then you're likely to have, it's hemolysis. It's a form of hemolysis. It's a form of hemolysis. The red blood cells are being hemolyzed. So once the red blood cells are being hemolyzed, then you're going to wind up having low folic acid. You can't be hemolyzing and don't have relative folate deficiency. Everyone who is hemolyzing, no matter the reason for the hemolysis, you're going to have relative folate deficiency because folic acid is needed in order to make new red cell. So as you're hemolyzing, the bone marrow is attempting to make new red blood cell. To do so, it needs a whole bunch of stuff, but the most immediate thing that it needs is folic acid. Okay, so therefore, you're going to become folate deficient, and then you're going to have to provide folic acid for these individuals. So right away, don't tell me about the fact that the red blood cell indices is likely to be normal. Yes, ordinarily the white blood cell will be large, so the MCV will be large. But you have multiple processes going on simultaneously that's going to cancel out these, so don't waste your time looking at this right now, because that's not what's going to happen. That's elementary stuff. You got to think at a higher level than that, because you have hemolysis going on, you have bleeding going on, you have myelosuppression going on. Because remember, cirrhosis of the liver is an inflammatory disease. The inflammation that's taking place in the liver suppresses the ability of the bone marrow to produce red blood cell as well, because the transferrin protein cannot carry the iron that is needed to the bone marrow to be incorporated into the early red blood cell to produce red blood cell. Cannot do it, so the iron backs up. So you have that process going on. So you have myelosuppression, you have hemolysis going on, and you're likely to also have bleeding going on. So you have to have all these things in your mind simultaneously as you're trying to sort them through and to deal with them, okay? So this is a major complication. Now, the bleeding got worse when it involved the portal pressure. And by the time I get to next week, I'll begin to tell you about something called varices. This is the stomach. How do you go from here to the spleen to the stomach? Well, you go to the stomach because the stomach has, the beginning of it is the esophagus. And because of the portal pressure that's blocking these things, you're going to have neovascularization of the esophagus, causing this thing to occur, resulting in bleeding. Listen, I'm stopping here. Next week, I'll continue the talk. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.